السلام عليكم، رمضان مبارك. شكرا لوحدة التعليم المستمر وحدة ابن سينا، دكتورة زهراء سيل ودكتورة سليمة، السيد العميد دكتور سرمد هاشم. It's part of the continuous education program at the University of Baghdad College of Pharmacy. Thank you to the Dean Sarmed Hashim Al-Khatib and the continuous education director Dr. Zahra Ashel and the Ibn Sina director Dr. Salima for their support. And we would like to thank our guest from Spain. A little bit introduction about Dr. Carlos Bezos. He is director of the Institute of Experienced Patients since 2016. He has directed numerous patient experience projects for health ministries, hospitals, clinics, and lab in Spain, Italy, Germany, Colombia, and Brazil, as well as European projects. These projects have generated several scientific publications. He is specialist in patient experience, an expert in PREM, and teacher of the patient experience subject on several health master degrees. He has also set up a first university course in patient experience with the Ray John Carlos University. Previously, he has quality director of the IVF Spain and manager of the DO Shared Service at the Mercedes Spain. Thank you so much, Dr. Carlos, for accepting the invitations on the behalf of the Dean, Prof. Dr. Sarmed Hashim Khatib. We welcome you at University of Baghdad Continuous Education program. Our audience are mixture from pharmacists and postgraduate students, and we are looking forward to hear about the Spanish healthcare system, which is the part of the two lectures today. The first one will be presented by the Dr. Carlos Bezos from Spain, and the second one I will introduce different healthcare system around the world. So, Dr. Carlos, the stage is yours.
Thank you very much, and happy Ramadan to everybody because it has started. Well, let me introduce you a little bit about the Institute for Patient Experience, not very long. It has been the reference, not said by us, but by the Spanish Society of Quality in Healthcare. And as Dr. Aziz said, we work in several countries. And well, we have some landmarks, which is that we work evidence-made, we created the first certification in patient experience. It's not 15, it's already 30 publications, I think. We host every year the annual Congress of Patient Experience, and now we have started the first university course in patient experience. I will go over that very quick. And what is important for you is the healthcare system. So first I will start with the healthcare systems in Europe. Not very much, just a little view from the air, since Dr. Aziz is now going later to explain the healthcare systems in the world. So in Europe, we have, you see these black and white pictures of men ruling long ago, one in the 19th century and one in the early 20th century. This is the key of what we call the Bismarck systems. You see them in red in the map, and the beverage systems in blue. Both were military. Bismarck, you know him, no? He was responsible for German unification, which he did in a military way. So he set up in this Prussian manner the German healthcare system, linked also to pensions for retired people, because he wanted to counter a little bit the risk of socialism in the country, or of revolution. So he established a system where the people paid to an insurance company, which can be public or private, and this insurance company covers then the expenses for healthcare. Lord Beveridge, he came from the social side, but then in World War II, he was also involved in the war, and he was very keen on logistics. So no wonder healthcare systems are based on military and logistic structures in their very beginning, or military logistic structures, because this was the time of a more military way of understanding organization, no, and dealing with hierarchy. And his approach was a little bit different. He didn't want to combat socialism, because he was already from the social democratic side or the labor side. He wanted to spread equality, and so the approach is different. It's not we pay into an insurance and the insurance covers, but the insurance belongs to everybody or to the state, and the state organizes everything. No, these are the main differences. Well, sorry, because this is in Spanish, but mainly I translated for you. The Bismarck system is, as I told you, paid by insurances, and this insurance contract hospitals, nurses, and so on. And in the very system, it is the state that regulates everything and gets the money, whether from taxes or from what people pay. A part of the salary is taken apart to finance Social Security. So we have here a table where we see, the beverage system is universal. It is for every citizen. It is financed by taxation. It works like a flat rate, and the social partners are uninvolved, and the state doesn't play a big role. Sometimes bigger, sometimes less big. For instance, in the United States, the state doesn't play any role at all. And the Bismarck system, the point that you're entitled is your employment, because when out of your employment, you pay the contribution for the insurance. No, it is related to earnings, and it is a full state provision. So the Spanish system is a beverage system. It's universal. It's paid by taxes, and it ranks. Later we will see. Depends on the kind of ranking, but it's considered one of the good examples and efficient examples. Though it has a lot of difficulties, especially after COVID pandemic. The system is now under big tensions, this is true, but it still is one of the good and efficient systems, not only in Europe, but worldwide. It ranks here 8th, and we would have before South Korea, Taiwan, Denmark. There are other rankings that say Switzerland and the Netherlands are the first, and Spain ranks more by the 20th, and Northern by the 8th place. No, but it depends on how you measure and what indicators you use. So a little bit about the Spanish system. First, a little bit about the history. Regarding the rankings again, sorry, before entering to history, it depends. The WHO says Spain is the 7th, others say it's the 5th, others, Bloomberg says it's the 13th, but in any case, it belongs to the best ones worldwide. No, there is not a birth hour of the Spanish healthcare system. Before the Civil War, there was a little bit of Civil War is almost 100 years ago. There was a private provision and a little bit of public, but not much. So in 1942, there was a compulsory health insurance just after the Civil War. It covered salaried workers, and these were not the main part of the population. Many people lived at that time in the countryside. So the system became with the time more and more inclusive, in the sense of including more population. So from the 40s to the 60s, it was like a charity. Also, church played a role as a owner of hospitals, the Catholic Church, and the big change was in the 60s with the law for Social Security that extended the coverage to workers and their families, and with the advent of the democracy in 1975, when Franco died, and 78 with the Constitution, it was regarded as a fundamental right. It's in the Constitution, and the creation of the primary care network was taken in place. No, so but the change, as I told you, came with democracy, and 10 years after Franco's death, there was, and this is the big change, the national health system was created by a law of 1986, and it established that it was public funded, so that everybody could access, that primary care is the pillar of the system. Later we will see primary care is the pillar, but it's a bit an endangered pillar nowadays. And the other big change, we had a centralized healthcare system. All the decisions were taken in Madrid, and now every region has autonomy. I would say the truth is that there are 17 systems that are coordinated. We will see later the difficulties that this supposes. It has advantages and disadvantages. Until now, advantages were higher, but now when resources become scarce, we see that it can be disadvantage to have it so decentralized that it can be regarded as fragmented, no? And well, what I told you, the regions have now, or autonomous communities as they are called, they have the power of each for each health system. So it's not a national, but it's the sum of 17 healthcare systems coordinated by the healthcare ministry, and we will see that. No, now just that you have some idea of the numbers. This might change, but we can say it's a success. You see, for instance, the life expectancy at birth has increased. Also, the healthy life years, almost all indicators have become more positive. But we are witnessing now, we don't know if it's a trend or if it's just something seasonal, or it's also that things cannot grow until infinite or endlessly. And we see that life expectancy for this year, in 2024, it was the first time that it went a little bit back. Okay, it's not a debate yet, but we might have come to a limit. Also, if you pour money into the system, it doesn't mean that you live longer and the service is better. There is a limit for everything, no? And regarding the structure, the coordination is the health ministry system. This is this ugly building. If you come to Madrid, you will see it's in front of the Prado Museum. And well, now it's protected because it's old, but it's really ugly and well, never mind. What is important is the ministry is responsible for the national policy, for the national strategies, for instance, the strategy for respiratory healthcare, the strategy for vaccination, and so on. No, but the power and the competencies is in the hand, or are in the hand, of the regional health ministries of the autonomous communities. They are responsible for planning, organization, and they are responsible for the budget too. This means the national health ministry has almost no budget. So this is a little bit one of the points I said. It could has advantages and disadvantages because we witnessed in the pandemic during COVID that some regions, for political reasons, wanted to make a difference with the central government, and they refused to follow certain laws. No, this is unconstitutional, but this can happen, and this is a problem because the national ministry, let's say, has a respect but has no real power. No, and below the regional health ministries, you have the public health service, which is the network of hospital, healthcare centers, primary care centers, and so on, that provide the care. And they are reporting to the regional healthcare ministries. So the roles are that the central administration establishes the basic regulation and coordinates and tries to ensure equity, because one of the problems that this system has is that it has started to show signs of inequity. I will tell later, some treatments are approved in some regions, others not. And this is, for instance, we have done a study in sarcomas, and it's a real problem, no? And the communities, the autonomous communities, they have all the power, as I told you, and the organization of the healthcare services, and there are local governments that are, for instance, town halls and so on, that are involved in the management of certain healthcare programs, but this is not really very important. So, as I told you, the pillar is the primary care, and then you have the hospital care, of course, which is the other pillar. So the primary care used to work very well. Now it has a lot of problems because it's very tensioned, especially after the pandemic. And I will explain later how it works. But basically, it is your GP, your general doctor, and it has a very well renowned reputation of making good follow-up, which means one part of this long life expectancy of Spanish population is because their general practitioner knows the patients for 15 or 20 years. So this means that and as also literature proves, if you have a long-term relationship between doctors, nurses too, and patients, the life expectancy is longer, no? So this is everything which is follow-up and non-complex and early diagnostic and prevention, and specialized care, which is everything which is in the hospital. And of course, both have to be coordinated. And there are, for instance, in Madrid, in the Autonomous Community of Madrid, there are figures that coordinate both, but in others, those figures do not exist because, as I told you, every local government is autonomous, and they can organize how they prefer. But for instance, in Madrid, we have this coordination, but on the other hand, the health systems from primary and hospital care do not communicate. No, in other communities they communicate, but they are not coordinated. So we have these problems. The primary care system, as I told you, it is spread not only in cities, but also which is very important for rural population. Spain now has a problem of losing population in the countryside, in the rural areas. It has dropped by millions because people are still going to the cities, so they are very sparsely populated. These centers are now really difficult to fund because if in a village before, I don't know, we had 2,000 people, now we have 200. So it is very difficult to finance this, but they really are a factor of having the population there. For instance, I have a friend who is the local architect in a village in one of these not dense populated areas of rural Spain, and he says there was a big struggle between all the town halls in the area who was going to have the primary care center, because the one that wins this battle can retain population and the others lose population automatically. No? So it's the gateway for the healthcare system, and they try to solve most of problems because if you solve it at private care, you don't have the big expenses at the hospital. No, it's composed by multidisciplinary teams. We work a lot with them, and I must say sometimes they appear like gods to me because, in the sense of they have to know about all the diseases. No, and it's really really difficult to be at that level, and they really are people that are, the ones I know from our projects, really engaged and really trying to learn every day more and more to make good prescriptions, not only of treatments, but to prescribe the right or derivate rightly to the hospital. No, it's not easy when we talk about rare diseases or diseases that can be not very easy to diagnose, or where you need a multidisciplinary approach. Like it's not clear that it's, for instance, heart and lung. No, they often go together, and they have to do this work, and often they have 10 minutes per patient. and now they have really lack of staff and long waiting lists. It depends. For instance, where I live in Madrid, if I ask for termin, sorry, I forgot the name in English. When I go to appointment, maybe it takes 3 days, 1 week. But where my mother lives, in a crowded area of Madrid, it takes 2 to 3 weeks. No, so you can see in the same region we have these problems. No. So the problems now is that, of course, the funding is not enough, especially after the pandemic, and it is calculated that we need 20 billion euro, the American billion, 20,000 millions of euro to fund it, and many professionals, they simply earn bad and have long working days, and then they have to learn and study and write papers and do the administrative stuff, and so many just go and leave for other countries, like for instance to the United Kingdom. So these are now the main problems, and they will grow, and nobody knows where this 20 billion euro will come from, and especially now that we are debating if spending more in defense or not. No, and the other problems we have, not only in primary care, is that population is aging. I told you about rural areas. No, population is decreasing there, but increasing in cities. But aging in general, like in all Western countries, but also in China, in Russia, in Latin America, medicine is a success. Therefore, people live longer. And at this point, and on the other hand, in the West, at least, families have 1 kid or 2 or no kids, and so you don't have a feeling of younger people. No, what does this mean? That that we need we have a lot more of chronic conditions. They are very expensive. They need follow-up, expensive pharmacological treatments. They need often hospital intervention, and so this is one of the reasons primary care cannot be properly funded, because population is aging, and money has to flow in also in hospital care. No, and since we have this funding problem, aging population, also we get new treatments. They are from the pharma companies. They are far better, but also far expensive, personalized, genetic, and so on. Who's going to pay for that? And this creates a gap. And at the end, this is why doctors and nurses are not so well paid, and always less. And this is why we get unacceptable waiting times. For instance, we had a project once to try to reduce the waiting time for back operations, which were of 2 years. No, it is really unacceptable. No, so Spain, it is true, it ranks among the best systems worldwide, but it has also on the other side these problems, and I don't want to hide them. They are there. No, and then we have the point of inequality. The portfolio of services is not homogeneous. Some regions offer, for instance, expensive cancer treatments, and the neighboring regions maybe not. So we have here a problem. And what happens in regions where due to geography, it happens, for instance, in the Basque Country, people have to cross to Navarre or to Castile or otherwise, because the nearest big hospital is near the village is on the other region. So they have like a special agreement between both regions for these cases, but in one places you get this cancer treatment, and in the other not. No, so we are all citizens of the same country, although we are divided in regions, and so this creates inequality. Also, not every medicine is approved in all regions. I had arrhythmia, and I had to take, for this is an example, not because it's of me, no, it's general. I had to take an anticoagulant for one time, And it happened that at that time I worked at the coast, and it was funded. But when I came to my family in Madrid, it was not funded. No, it's just an example. But think of expensive, more expensive things. No, the other point is interoperability. Each region has its IT system. So how, if I have my medical records in Madrid and go for vacation, I don't know, to Valencia, and I have to go to the hospital, I don't have my medical records in the system. I have to bring them with me. Or even worse, as I told you, in Madrid, primary care systems and hospital systems do not communicate. They have small like windows between one and the other, for instance, for polymedication, so that you know in primary care what, or otherwise what this person, for instance, with heart failure has prescribed, but that's it, no? And we have also a problem of efficiency. It is true that having this decentralized structure on one hand saved a lot of money, because on a regional level you can plan far better, you can allocate resources better. This is true, and it has worked. But on the other hand, for instance, drugs, no, or other big purchases, no, it is not the same if a small region in northern Spain, like the Basque Country with 2 million inhabitants, purchases drugs, or if it of Madrid with 7 million inhabitants purchases drugs, or Andalusia with 8 million. But it would be even more efficient if Spain would buy all the drugs. No, there are conversations if Europe could do that, but we are not able on our national level to do so. No, so this is something that is really difficult to solve, because it's in the constitution on one hand, and on the other hand it's like a power struggle between different regions, because they are different ruled by different parties. No, so it's difficult that they cooperate. No. And this was the public healthcare, but we have also the private healthcare. You have to know at the end, here we have a statistic, 86% of users of the private health use public health. Only 5% go just 5% go only to private health, because we have a dual system. And we have public providers, private companies, and in many cases they partner. For instance, a regional government might say, please, company so and so, I have this hospital, I will give it to you for its management, and they do it for cost reasons many times, or not to build a new one, or if they build a new one, not to have like public clerks. Instead, if they can have private staff that you can hire and fire, no? And also for flexibility reasons, because if you contract with the state, it's long and complicated and bureaucratic, and if you do it over the private market, it's not so bureaucratic, no? I have to say also this is what the Germans call a politicum. It's not until now this dual system has worked well, but there are also some interests that are legitimate in some regions that the private system takes over the public system. And there is a lot of population resistance, but population loves the public health system. It's like in the United Kingdom with the NHS. They feel a strong identification. But it is true also, and this happens, that if you saw that we have some funding problems, if you don't fund, the public system will get worse, and if it gets worse, people will go to the private system. This is parts of politics, and it happens too. But I have to say the Spanish private system works pretty well. You have seen there was an increase of users, but they don't go away from the public. They have, if we have a long waiting list in the public system, they go to the private for the shorter public list. No, you have seen the the expenditure also grown by 20%, and the investment in technology has also grown. And I think they are very good also in using technology, digital health, artificial intelligence, because they are more flexible, more quick, and more innovative. This is true, no? So 24 of Spaniards, other statistics say 29, have private health insurance, as I told you, complementing the public health. There are 460 private hospitals from the 700 and something hospitals. It's more than half of it, no? And 29% is of the spending goes to the private sector, no? As I told you, it is very good in technology and also in oncology and complex issues. But if you have a real problem with respiratory or with a rare disease or with late onset, then you go to the public at the end, no? As I told you, there is a partnership with the public hospitals, and 35% of private hospitals have agreements with the national health system, and this is the role of the private health. Also, there are, as I told you, like the public has problems, the private has also some problems, which are not exactly financial, but sometimes it's too much business oriented. And there are studies that show that often doctors, instead of derivating patients to another hospital, to another service, for instance, with geriatric patients, this is very evident. They need geriatrists, but many internists or whatever, heart doctors don't send them away because they want to keep them because it is money, no? So for older people, they have a problem with that because they have a lot of medical records. They are if I go, for instance, to a cardiologist in one private hospital, but to an internist in the other, those health records don't communicate, no? So I have a lot of paper, and imagine old people, fragile, they don't understand often, and they are not properly derivated. This is a case. Also, when there are ethics, of course, but there have been cases where well, people that were not profitable for the insurance, then at the end they cannot cut the provision, but they triple the price, for instance. So
Dr. Carlos, sorry for the interruption. Can we wrap up in 10 minutes, please?
yes, we are almost done.
Thank you.
And well, it has a lot of advantages, no? The strength is you can collaborate public health and you have high quality of care. Problems, you have a big dependence on public health care, high cost per patient, and difference in coverages. So regarding digitalization, there is a lack of regulation, and there's a lot of pressure on health workers because they have to work double, no? But in public health, we have a good picture on digitalization. For instance, Catalonia is one of the leading regions in all Europe. 75% of patients in Spain have digital healthcare systems, and 50% of appointments were digitally. And also, with the Spanish system is one of the leading countries in Europe in digitalization, and this is true, no? Well, since I have to more or less finish in 10 minutes, just see this. If Dr. Aziz can give you the presentation, you have the figures here. 90% of hospitals have already digital records. 70% of private centers have online consultations, and they are used, and so on. No. So let me close with patient experience in Spanish healthcare. There is a difference between public health and private health, basically in what the goal is. No, the public healthcare uses patient experience for optimizing processes and quality of care, while the private sector uses patient experience as a way of prescribing to other clients and influence the the reputation. Both are very good in humanization. I think Spain is one of the leading countries in humanization. But while in the private sector, it is focused on comfort, in public health, it is focused on vulnerable groups, no? Regarding patient-reported experience measures, both are still in an initial phase, but the use of patient-reported outcome measures, they are growing, and in private hospitals it's really increasing, no? And just to compare patient experience between the USA, European Union, and Spain, I won't go really in detail, but we could say if the USA are, let's say, the reference of the world, no? In Europe, it's fragmented. Some countries like the UK are very well, and other countries like, I don't know, Estonia and the Baltic countries lag behind. So we would say that Spain is in the above average. It's not top, but we could say it's over the top 50%. No, it has made a significant process also with several with the use of PROM and PREM, that it's increasing with the patient first certification, with the congresses we held here. So I think it's also a point that has room for improvement and of growth in the next years. And I am open for you for questions if you have to answer them.
Thank you so much, Dr. Carlos, for the informative lectures. Since I will have a second lecture, do you need to receive questions and leave, or do you want to stay and have the questions at the end of my lectures? Up to you.
Well, I have to leave at 7 o'clock.
Okay. So we have a couple of questions about you say it's one of the top 50% of the healthcare system in the world. You have good digitalizations, you have good primary care systems, but you also struggle from funding. But I actually didn't catch the point. Is your system mixture of beverage and Bismarck? Do you have employer-based system, or you have governmental funded system?
It's full beverage, the public system. It's funded by the government, and it is universal. It is not Bismarck at all. The private sector, it's works over insurance, but as a private insurance.
So all people are covered by the governmental insurance.
Yes.
And the private one, it's optional. It's from their own pocket money.
Yes.
If they need to, is there certain gap? Is there a certain gap in the public, so people should go to the private?
Well, what we have is
people
waiting.
go to the private one when there is good public health system.
Because the waiting lists are long, and in the public health, you have always to go through primary care. So imagine I have, I don't know, a fasciitis in the foot, no? So I have to go to primary care and wait 3 weeks, and primary care then sends me to the hospital, and this is again 6 weeks, and this is too long. If I go to the private one, they tell me, you have fasciitis, then go to the physiotherapist, and we pay 10 sessions. So it's for little things, it is very quick and efficient. If you have a complicated cancer, then it is better to go to the public health.
We have a couple of questions from postgraduate student late saying, what's the role of clinical pharmacists? Do they have extra role other than dispensing? Do they have like prescribing authorities or working with physicians? Do you have any advanced pharmaceutical care in Spain?
The role of pharmacists, we have the hospital pharmacy, but they cannot prescribe. And the street pharmacy can also not prescribe. It is very regulated, but the hospital pharmacy plays a big and important role in educating patients first, in the right use of therapies, and second, in controlling expenditure and having this balance between expenditure and results. No, they really do good work.
So what's about the paying? Is it good considered with other healthcare providers? Like,
Well, the
or
paying
they
for a doctor,
struggle?
it depends. I think, for instance, the head of neurology in a big hospital earns maybe $5,000 a month. No, if it's much or not, in the UK, it's double or twice.
So they are struggle kind of in financially. So what's about the AI? Do you have any AI implemented in your system?
Yes,
Public, private?
and not now only. For instance, in dermatology, it has been working since 5 years for recognition of pictures. Also, it has been used for basically for data, and now it is starting to be used for diagnosis and so on. No, but this is starting now. But it has been used, as I told you, dermatology and ordering of data, making research. For this, it has been used for 10 years already.
What another postgrad students say, you have good technologies, why there is waiting list? Is there any co-payment or co-insurance patients
No,
should pay, or it's free of charge?
it's free of charge, but we have
Okay.
many people for a system that hasn't hired since 2015, and many doctors are old. But on the other side, on one hand, you need doctors and nurses, and on the other hand, you have too many. It depends on the time of the year or how work is organized. Recently, we had a project like, we cannot cope with so many migraine patients. There are too many. We have 1,000 a year, but we can only cope with 200. Who is coping with them? Dr. Nuria. And why not the other doctors? They don't like it. No, you see, this is this.
But you say it's 10 years you didn't hire a new, where those people going, like those new healthcare providers?
Okay, if people retire, you get new
Okay.
ones, but you don't get like before of the big crisis of 2008.
Okay.
They were more free to hire. So what we have now is, for instance, a problem because I don't remember the percentage, but in the next 5 years, a lot of doctors now 60 to 65 will retire, and nobody is preparing the replacement.
So the graduated physicians, pharmacists during the last 10 years, where they are working now?
No, they work in hospitals, but many have to go abroad to
Oh,
Sweden, to
so there
Germany.
is no good job opportunity in Spain for new graduates?
Not,
They
not,
have
not.
to wait until the old generation retire so
Yes,
they can join?
yes, yes.
Oh,
Oh,
so they
it's
have to
not.
go.
Not only that, it's that, yeah, we have now 50 million people, 10 or
Okay,
48. 10 years ago, we had 43 million people because we had lots of
okay.
immigration. So, but the number of doctors is the same. So if one retires, a new one comes in. But if you have two patients more in a part, you don't get two doctors more or two nurses, no?
That's why. So you don't have co-insurance. You don't have many healthcare provider. That's why you have long waiting list.
Yes,
Some students ask about the emergency unit. So everything is covered by the government. Like for
yes,
example, you are citizen of Madrid. If you go to Valencia, for example, if you have car accident or something, uh,
yes,
like people covered.
yes. One thing is that what I told you about inequality of treatments, but if I have any urgency, I will be
Okay,
treated. If I am an immigrant and have no papers, I will be treated.
you will be treated
Yes,
an emergency.
yes,
So
sure.
emergency open for all, even for non-citizen or for non-legal immigrant as well.
Yes, then later you might have a paper problem or whatever, but it won't
Okay.
lead to the aid. If you don't have resources, usually they don't charge you. If I don't know, if you come from the USA and treated, then you get a bill, no? But for immigrants have this thing, and because the point is not letting anybody die, no?
So the last two questions, is there any language barrier? Patients should speak Spanish. What about people like they don't speak Spanish well? Do you have any
Yes, it is interesting.
interpreters or something?
Yes, this is interesting because now we have a lot of immigrant population from
Okay.
the countries, from Africa, and
Okay.
Not everywhere you have a translator available. Translator, somebody translating, no. But it's when we made the prem for primary care in the north of Spain, this one of the points: how to treat immigrant population, how to make you understand, and so on. No, so at least there are mediation services, not a translator, but a mediation service.
What do you mean by mediation? Like, is there?
You have like from the social authority,
Okay.
you get aid for immigrants for integration.
They
And then
can ask someone to come to help to infiltration.
I don't know exactly how it works, but
Okay.
confronted with that, no, and it's a problem they have, but they try to give you the solution. I don't know if it works always, but it's not. Oh, you have to speak Spanish. No, you have no choice. No, they try to help you always.
So English is working as well.
In the coast, yes.
Okay.
In the coast and in the private sector in the coast, they have translators for the tourists.
Okay. Okay. I think, thank you so much, Dr. Carlos Bezos. It's a wonderful experience, and the lecture is really informative. All the grad students, pharmacists appreciate the rich information about the Spanish health system. And on behalf of the College of Pharmacy, University of Baghdad, we really appreciate you are accepting the invitations and your valuable time, and hopefully we can see you again in another topic. Thank you again,
I hope
Dr. Carlos.
it was a pleasure. Shukran, Dr. Aziz, and shukran to everybody of you. And I'm sorry that I have to leave, but here it is late. I have children.
Yeah, thank you so much.
Because I really would like to listen to your lecture. Okay, thank you very much.
That's fine. Thank you.
Goodbye.
Thank you. Thank you. Have a good night. Thank you so much again. Thank you. شكرا لجميع الحضور. دكتور كارلوس راح يغادر. عندنا المحاضرة الثانية إن شاء الله راح نبلش بال Okay, healthcare system, this one. واضحة دكتورة سليمة يعني المحاضرة هسه لو أبي مشكلة؟ السلايدات؟
دكتور علي واضحة عيني واضحة دكتور
شكرا.
علي.
شكرا جزيلا. شكرا. Thank you so much. We already listened to Dr. Carlos lectures from Spain, and we go overview about the healthcare system around the world. So I'm Dr. Ali Aziz Jumaili. I'm the faculty member at the University of Baghdad College of Pharmacy. Thank you so much for the audience, and on behalf of the College of Pharmacy, we appreciate your attendance and attention. So today we'll go fast overview about the Iraqi healthcare system, the US healthcare system, Canadian, and the UK, and we will lay out the principle of any healthcare systems. I think Dr. Carlos talked about the Spanish one, which is kind of public one. In general, to define the healthcare system or any system, we have structure, process, and outcome. Structures, we have the settings, we have the providers, and chemicals, products, medication, resources. While process, it's the relationship, it's the activity done by those personnel. And the outcome, we refer to the patient outcome, satisfaction, clinical outcome, humanistic, economic outcome. So we are working hard to increase the quality of the system, but at the same time, when you need to increase the quality, you have to increase the cost. And it's very hard to increase the quality and reducing the cost. In general, we have 4 types of healthcare system around the world. Beverage model, which is the public model. It's similar to the Iraqi public healthcare sectors. It's work as we listen in the Spain, in UK, other Scandinavian countries, when the government own the healthcare settings and the providers are employees for the government. While the second one, which is the benchmark model, it's the health insurance model, when we have providers, when we have the beneficiaries, and usually the employer pay most of the charge, and we have the co-payment. We have national health insurance model, which is the Canadian one. Usually the government pay to the private sector to treat people. The last one, which is not exactly system, we call it out-of-pocket system. When we have in our private sector, when there's no system, people should pay out of their pockets directly because there is no insurance. So beverage model, it's a British one. As we heard, Spain also is beverage, so it's totally funded by the government and it's free. So beverage model, we can say our public health sector, it's totally beverage model, again, because the government owns the healthcare settings while the providers are the governmental employees. So people will not pay, or they pay something like not the exact or actual price. The government pay almost all the fees. So we have two healthcare systems in Iraq. We have the public, which is the governmental one, and the private, which is the outside the governmental. So the Iraqi healthcare system is not ranking well. You know, we are in the 137s among 190. So we have real challenges, and we need to identify these challenges. And as we heard, Spain has good digitalizations, and we hope we have good digitalization as well. And also we need to enhance the primary healthcare settings. As we heard from Dr. Carlos, primary healthcare setting is really good in integration of the management. So Iraqi, the ranking of any healthcare system, it's rely on the average of life expectancy, healthcare access, quality of healthcare services, and the cost. So we heard from Dr. Carlos, Spain has like the life expectancy 84, while Iraqis in early 70s. So we have 10 years difference in the life expectancies and the quality of healthcare service. We need to measure them to understand where we are now at the quality. The cost, as we mentioned, the good things in the public healthcare setting, it's free of charge. And while the private one, there is no subsidies. So we always, as Dr. Carlos said, we always have limited budget. Iraq has also limited budget to healthcare systems. And unfortunately, the healthcare system received only 7.2% of the total governmental budget in 2023. That's mean the healthcare system, and most of this funding is related to we call it employees' salary. So only 1% is going to the capital, while most of the budget going to employees' salary. So we don't have much fund for healthcare systems compared to other countries and neighboring countries. So we have limited budget. So we have a limited budget, so it's very high. We need to have good pharmacoeconomic study and health economic study to make sure we use our resources very well. And going back to the public sector, the good things about public sectors, it's free of charge, and it is universal. Universal means everyone is insured, and all people can go to the healthcare settings, public healthcare setting, and receive treatment without charges. Emergency, primary healthcare settings, and public hospital, they don't charge money, or they charge very, almost nothing. Like they charge 3 Iraqi dinars or 5 Iraqi dinars, which is not more than $3. Those are nothing compared to the actual cost. So single payer, the government pays everything in the public sector. It's universal, everyone is insured, everyone is covered, and mostly free of charge, which is good. Those are the 3 good characteristics of Iraqi public healthcare settings. The downside, it's fragmented. We don't have electronic health records in most hospitals. We started to get better in terms of digitalizations and some rare disease and tertiary centers, but it's not that common nowadays. And it's totally rely on the paper-based, so it's time-consuming. We cannot retrieve data of the patient easily. So we need to measure the quality in the public sector, and we need to measure patient satisfaction. So patient satisfaction, we need to measure them, and we need to measure the people access. Do we have enough wheelchair sidewalk? Do we have enough ambulances? Do we have enough accessible parking? Do we have enough elevators, on-site parking? Those are matters. So our public hospitals, they don't have good parking site. They don't have a good sideway for the wheelchair people. So I gave example about the beverage model, which is first Iraqi healthcare, public healthcare sector, which is beverage model. Second example is the UK, which is NHS healthcare system. NHS, it's received about 8.3% of the GDP of the UK. It's also another example of the beverage model. It's similar to the Iraqi public sector, no average family premium. People will pay nothing when they go to healthcare providers. So there is no co-payment, there is no co-insurance. So we have problem in Iraqi and the UK healthcare system because there is no co-insurance, no co-payment. People will have something called moral hazard. People will visit the healthcare setting frequently for not that urgent conditions. So we may have long waiting list as Spanish healthcare system. It's also universal. Everyone is covered. And it's similar to the Spanish one. They have good primary healthcare settings. People should go to the primary doctors. So primary doctor keep all the records for them. They transfer them to the tertiary center specialist physicians. And those information from specialists, they should come back to the primary doctor. So we have integrated system. The primary doctors knows everything about the family. They can advise them about all these conditions. So we have the informations and the record of primary doctor, which is good. The UK system is one of the best among the European and developed country. They have integrated healthcare systems by the primary doctor. So general practitioner, primary doctors working very pivotal role to integrate the information of the patients. So as you can see, the UK system here, it's one of the best. Like here, affordability number one, preventive care number one. It's really good with the limited budget. They have only 8.2%. So we have another system. So we are done with the beverage model. Now we are moving to the out-of-pocket model. Iraqi private sector is one good example about out-of-pocket. People, there is no subsidies. People should pay out of their pockets. And if they have money, they can go to the doctor. If they don't, so unfortunately, they may not receive their healthcare. So Iraqi healthcare private, it's really growing. It's getting better with the time. It's totally out of pocket. We have health insurance, limited health insurance now. So we call it fees for service. That means they need to pay for the physician, for the pharmacy, for the lab, for the examination. So fees for services, they need to pay for every single patient's fees. And in this case, we may have something called provider-induced demand. If the healthcare providers ask the patient to conduct certain exam, unnecessarily exam, so we call it provider-induced demand. So it's relatively expensive. Not all people can afford it in Iraq. We still have limited emergency room service in private sector, so the people with severe conditions may not be accepted by the emergency unit at the public hospital, the private hospital. They should go to the public hospital. So we are done with the beverage. We are done with the out-of-pocket. Now we are moving to the third one, which is the benchmark model. Bismarck model, we have health insurance. We have provider, we have beneficiary, which is the patients, and we have the third party. It's common in the US, it's common in Germany, Belgium, France, Japan, Switzerland, Latin America. So basically we have the insurer, which is the insurance company. We have the insurance company or the healthcare authority. We have provider, which is a physician, pharmacist, anyone. Consumer, which is the patient or beneficiary. So we have third party. There is, because in the private sector, we have two party, patients and provider. While in the Bismarck model, we have the third party, which is the health insurance company or insurer. So we have to understand some terminology. Moral hazard, when people have insurance, they will use or overuse the healthcare services because they are insured. There is no co-payment, for example, as in Iraqi public sector, as in Spanish care sector, as in NHS. People overuse public healthcare services because they pay nothing. So we call it moral hazard. To reduce the moral hazard, the US and the Bismarck model, they impose co-payment or co-insurance. Partial money should be paid by the patient for every single visit. So discourage them from the overuse or misuse of the services. So provider-induced demand also happen when patient pays for every single service. So provider may prescribe unnecessarily treatment or unnecessarily exams because they may benefit from them. We call provider-induced demand. So first party is the policyholder or beneficiary or patient. A premium is the monthly payment by the beneficiary to the insurance company. Second party is the healthcare provider, physician, pharmacist. Benefit is the healthcare services, and the third party is the insurance company or insurer. So to discourage people from overuse of healthcare systems, there is something called co-payment or co-insurance. Patients should pay either fixed amount, for example, $15 per visit, which is called co-payment. If the patient pay 10% or 20% of the total fees, this is called co-insurance. So co-insurance is a percentage, while co-payment is fixed amount. Detectable, that's mean people should pay, for example, $4,000 before health insurance starting to work. So all these, when I was at the US, people, they need to choose the lowest premium, but the detectable is high, co-payment is high. So the insurance company, they usually have different strategy, either low premium, high detectable, or low premium or high premium, low detectable. So it's really challenges for people to choose. Out of pocket, as I said, people pay all the amount of money. And United States, one of the most expensive healthcare systems in the world, they have good payment for the healthcare providers. Dr. Carlos say healthcare providers in Spain, they don't get enough payment, so they have to work abroad. The US is really expensive healthcare systems, and it's not universal, and it's mostly Bismarck model. It's mostly employer-based model, and people who are working for large companies, they usually have good insurance, while people who are independent or small companies, they may not have good health insurance. And the average premium for the family is $1,115. And when even you have insurance, when you visit the emergency room, you need to pay almost $100. And for every single visit, a patient may pay $15. So it's not universal. So some people don't have health insurance. Unfortunately, 10% or more in the US, they don't have health insurance. They are insured and uninsured. So they may not have access to healthcare system or services, and they go to emergency room or other places or free clinics. So still the US, the Obamacare tried to cover those people, but I'm not sure if I think they are still, some people, they are not covered due to the premium, because it's not free. People to have to pay premium, co-insurance, co-payment, and if they don't have good income, they may not have access to healthcare system. So basically, if you are employer for the government, or sorry, if you are employer for the university, so the university will contract with health insurance. So for example, the university will pay 75% of your premium, and you have to pay 25% of your premium. For example, I was paying $400 to my family when I was working at the University of Iowa. So the university pay 1,000, and I pay $400 to the insurance company. So you are insured via your employer. So quickly, Taiwanese healthcare system is also Bismarck. We have third party, which is the government or the Taiwanese Health Insurance or National Health Insurance Institute. So the people, Taiwanese people, pay to this insurance authority, and the insurance authority pay to the healthcare providers. They also have to pay premium. It's similar to the US one. It's similar to the US. Co-insurance, co-payment, and premium. But it's affordable. So it's GDP in the Taiwanese 6.3, which is lower than UK, lower than the US, and still doing well. It's only 650 average in premium for the family, and they have to pay 20% co-insurance. The good things about the Taiwanese, I hope we have such a health insurance card, which is a smart card. All the information, medical information of the patients inside this card, and people carrying this card, and they can go to any healthcare providers. They can put it in the machine, and they will read all the information. No need to carry out your history. So you only carry out your smart medical card. So it's universal. It's no waiting time, equal access. The Taiwanese is really good healthcare system. Iraq has a new health insurance program. It's in the pilot study. I think they are moving from 300,000 patients or beneficiary to 1 million this year. I have a friend in the health insurance institution, and they told me they are moving from 300,000 to 1 million employees, governmental employees. They will be enrolled in the Iraqi health insurance program or coverage. So it's kind of obligatory for the governmental employees, not all of them till now, but it's good because it's covered private and public healthcare services, and people should pay premium, which is 1% of their salary, and they should pay co-insurance about 25% of the medications, X-ray, and private clinic. So 1%, it's a premium for most of the governmental employees, and it's free for the low-income people, the people who are in the welfare systems, and they have disabled people or other sectors. So we have exemption from the premium, and people should pay 10% of co-insurance when they visit dental X-ray lab, and they have to pay up to 25% of their surgery in the private hospital. So it's good. It's enable people to use private services, and they help them to pay 20 or 75% of the fees by the insurance, while only 25% by the beneficiary. So this is part of my study with Haider. He's my previous grad students. We conducted these studies, the experience of physician and pharmacists, or expectation about the implementation of healthcare systems. As you can see, it's similar to Taiwanese. We have beneficiary, we have healthcare providers, we have health institutions or healthcare institution or authority. So people should have premium, should pay insurance, and they will receive healthcare services. So it's similar to Taiwanese. Also, it's similar to the employer-based. This one, I can say it's Bismarck model. So this is one of our publication with Haidar Naji. He's our graduate from master degree. We asked the pharmacists and physicians their expectations about the implementation of the new Iraqi healthcare systems and about the expected challenges. The pharmacists were supporter. They expect people will have more access to the private sector because it will be covered by the health insurance. They expect the quality of service at the public sector will increase because it will be in competition with the private sector. But also they are concerned about some misuse, such as moral hazard by patients, because we need to have electronic health record to make sure all the information shared between health authority and provider and the hospitals. Also, they have concern about the delaying in the payment to the providers. So as I know, we have pilot implementation in the private department in the public hospitals. So they have good expectation because they expect patient will have good accessibility and good affordability to visit the private healthcare providers. We also ask the physicians. We published this in the Faculty of Medicine, College of Medicine at Baghdad University Journal. We ask the physicians, and the physicians say, also we are supporter. They also expect will improve the quality, will improve the accessibility, will improve the affordability, but also they concerned about the moral hazard, about the workload in the private sector when it's covered. So they give recommendations about we need expert in the field, we need electronic health records, we need to have pilots. So we are come to the last healthcare system, which is the national health insurance model, which is the Canadian model. Health insurance model, when we have the government pay to the private healthcare provider to provide service. So patients will pay nothing, will pay no premium, nor co-payment or co-insurance. And there is no public healthcare settings, it's a private, but the government pays to those private settings or provider. So Canadian healthcare settings, they have 15 according to the territory or according to the provincial one. So usually we have the payer, which is government, the provider, which is the private provider, while the beneficiary citizen. It's good. It's have public administration. So the government will process the payment. They have one payer. It's comprehensive, cover everything except dental and I think eyes, something. Portable, so all people covered in all provinces, while in the US, it's not portable. That's mean if people insured in Iowa, if they have accident in another state, the insurance company may not cover the expenses. While the Canadian is similar to the Spanish one, it's portable, it's universal, everyone is insured. So it's universal. The US is not universal, it's accessible. So they have health insurance card, but it's not smart card. It's only have basic information. The disadvantage, it's because it's free of charge. There is no co-payment. There is no premium. The people may overuse it, and they have long waiting lists, as Dr. Carlos saying in Spanish, and we have long waiting lists in public sector in Iraq as well. So compared to the US healthcare system, Canadian healthcare system, they have very long waiting list. They have to wait for several weeks to get appointment with the specialist or tertiary center. So to summarize the lectures, we have 3 healthcare system in Iraq. The public healthcare sector, it's follow the beverage model, which is the public one. The private sector follow the out-of-pocket, while the new health insurance plan follow the Bismarck. We hope our healthcare system adopt digitalization, electronic health records. We hope to have the smart card with the full informations, and we need to implement some quality measures to enhance the satisfaction of patients. And we need to have, to reduce the fragmentations, we need to have connection between the private and public to share the information. We hopefully we can use the primary healthcare settings more efficiently, so the primary doctor will have all the information about the physicians. I'm done. Thank you so much for your listening, and let me know if you have any question. I think in the chart, I will see if you have questions in the chart. طلاب إذا عندكم أي سؤال، الأمور زينة. تمام. إذا ماك السؤال thank you so much for your listening. شكرا جزيلا للحضور جميعا. شكرا جزيلا لوحدة التعليم المستمر دكتورة زهراء سهيل ودكتورة سليمة من وحدة ابن سينا. شكرا جزيلا للسيد العميد دكتور سرمد هاشم الخطيب. مثل ما عودتكم كلية الصيدلة جامعة بغداد، احنا نحب نقدم ما فيه المحاضرات ونستضيف محاضرين، نحاول نقدم انه محاضرات مختلفة بحيث شير اكسبيرينس. يعني الحمد لله احنا اليوم كنا سعيدين باستضافة الدكتور كارلوس، قدم لنا نبذة مختصرة عن النظام الصحي الاسباني اللي ممكن نستفاد من عنده، مثل ديجيتاليزيشنز، مثل برايمري هيلث كير سيتنجز. حقيقة نحتاج نسمع من تجارب الآخرين عم نستفاد من عندها. فشكرا جزيلا لحضراتكم، وما أطول عليكم بعد أكثر، ورمضان مبارك وتصبحون على خير. في أمان. شكرا جزيلا دكتور سليم الدكتور زهراء، ممنونين جدا.
الله
تصبحون
وياك
على خير.
دكتور علي، كل
شكرا
التوفيق.
شكرا. مع السلامة.
مع السلامة.